This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I am sitting here this morning with Dr. Lena Napolitano, one of our loyal CSAP 17 authors, who has agreed to speak with me. Lena, before we get started, can you share with our audience where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, if you ever have one of those?
Good morning, John. Certainly. So I am here at the University of Michigan. I've been here since 2005. My role here is as an acute care surgeon, and in a standard month, I would spend a week running the surgical intensive care unit, a 20-bed ICU. And then for another week, I would be manning one of our 2 acute care surgery services. And then we have a night call in between there, and alternate that 2 out of every 3 weeks.
Not a quiet week, so to speak, I bet.
So true.
Well, I've asked you to share some of your thoughts today on critical care issues that are mostly found in the critical care category of CSAP 17. I say mostly because I have taken some CSAP 17 questions that we will discuss, but others are from questions that were written and discussed by many of the committees, but not selected for the final draft of CSAP 17. I actually selected those because they seem to create, I won't say dissension among committee members, but certainly a lot of discussion. So I want to pick your brain about some of those topics. So if that's okay, let's get started. And the first topic is sepsis, which is always a good place to start, as it was discussed at each of our 9 committees. And we had some new definitions to struggle with this time. Would you be willing to review those definitions for us and especially tell us what has really changed?
Most definitely. The new Sepsis 3 definitions are still a point of controversy and a lot of discussion in the critical care community. To be brief, the Sepsis 3 definitions were published in 2016, and they really moved away from infection, inflammation, and completely abandoned the SIRS criteria, the systemic inflammatory response criteria, and instead moved towards organ dysfunction using SOFA scores. So we used to have SIRS, sepsis, severe sepsis, and septic shock. And now we really just have 2 categories, sepsis and septic shock. So let me review those new definitions. So sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. But in effect, the way we, determine that a patient has sepsis is using these clinical criteria of SOFA score. And so the new definition says that you have to have an acute increase of 2 or more SOFA points as a proxy for organ dysfunction. And I think many of us find that very challenging at the bedside. We have put the SOFA scores in our bedside ICU books, but it's very challenging to calculate that on rounds compared to what we used to do with SIRS. But nonetheless, that's the definition of sepsis. And that definition carries a mortality rate of about 10%. And then the second definition is septic shock, and that's defined as sepsis patients who have circulatory dysfunction and require vasopressors. But an important additive to the definition of septic shock in this iteration of definitions is that the patient has to have a serum lactate level greater than 2 despite adequate fluid resuscitation. And in this definition, the hospital mortality is approximately 40%. And if I can give you my personal opinion, I have more concern with this new definition of septic shock because our prior definition of septic shock that really was the same clinical criteria, they have sepsis and they have vasopressor therapy because they have hypotension, despite adequate fluid resuscitation, those patients still have a mortality rate of 30 to 35%. But we are not including those patients in this new definition. You have to have a lactate level greater than or equal to 2. So there's still controversy. There are many organizations, the American College of Chest Physicians, IDSA, ACEP. Really, none of the emergency medicine or hospital medicine societies have really accepted these definitions at the present time.
And just to be clear, we're talking about what's called the quick SOFA in those definitions.
Well, the real definitions, the sepsis 3 definitions, in ICU patients, you are supposed to use the true SOFA score that was initially described by Jean-Louis Vincent and his colleagues, and that's this big table that has, 4 or 5 criteria for each organ. And QSOFA was meant to be a screening tool for patients on the floor. So we're not really supposed to use QSOFA for the ICU patients. QSOFA was meant to be sort of a quick and dirty screening tool. And there's controversy about that as well because particularly in surgery, many of our surgical patients will have a QSOFA score that's abnormal because they have tachycardia, they have a little bit of abnormal mental status related to pain control. So it's very similar to SIRS, like many of our surgical patients had SIRS because of their inflammatory response. So I personally don't see a huge advance in the new definitions, and we'll have to see what happens over time.
Actually, the idea of surgical patients with any of these scoring systems brings back memories of how we applied the Apache and Apache 2 scores, which had pretty much the same problem, if I remember correctly.
So true. Exactly the same issue. And that's why I think many organizations, societies, have actually asked for additional validation of these new sepsis definitions.
Let me go back to the SIRS problem, and I think I've already identified your bias, which probably correlates with my bias, but I still believe we see lots of people with what you and I think would identify, and most people would identify as SIRS, but they really do not have an infectious source. Is that fair?
That is totally fair, and I agree fully with that statement. Yet it is a great tool to evaluate a patient who has SIRS to be sure that we are not missing infection. And so I don't mind that, even if you told me that of all of our surgical patients, 6 or 7 out of 10 don't have infection, I'm trying to find those 3 that do. So SIRS is still a good screening tool. And particularly outside of the U.S., SIRS is still used as a screening tool for sepsis all around the world because it's very easy to do.
Let me ask you, has all of this manipulation of definitions changed our clinical intervention or our guidelines?
It has not to date because we're not really using those definitions to alter treatment strategies. I think initially the organizers thought that one of the good, maybe potential benefits of having a new definition is if we could find this very high mortality cohort in septic shock with the elevated lactate, those in the future could be a source of study since many of our septic shock medication trials have been negative. We could focus on that cohort to potentially identify new therapeutic treatment strategies for sepsis and septic shock. But in terms of, the guidelines really have not changed based on those definitions.
Okay, and I know there's no controversy around the guidelines, but let me probe that a little bit. Is there a fluid that's preferred in sepsis for resuscitation?
Yeah, so the current guidelines, and I really agree with this, is that crystalloid for most is the fluid that is preferred in sepsis. I think the bigger controversy is that in the new 2018 sepsis bundle, the recommendation is to rapidly administer 30 cc's per kilo of fluid. and that the new sepsis bundle is now an hour one bundle, so, meant to be accomplished quickly. I agree crystalloid for most, but we are very careful with fluid resuscitation, and we transitioned to albumin based on the results of the Italian ALBIOS trial that did confirm that there was a signal for decreased mortality with albumin resuscitation in septic shock. Now, that was a septic shock definition using the sepsis 2 definition, so you didn't have to have that high lactate, you just had to have a requirement for vasopressor. So most of the time we use crystalloid, balanced crystalloid.
Is there any movement to limit that crystalloid amount? You mentioned using albumin, but most of the time albumin still has salt associated with it. But we're now limiting fluid in hypovolemic shock. Do you think we're going to move to do the same in septic shock?
Absolutely. I really feel like, again, particularly that 30 mLs per kilo is not an appropriate recommendation. We should be providing personalized resuscitation care. We feel strongly that we really need to assess fluid responsiveness frequently. If you're giving a fluid bolus in septic shock, following that fluid bolus, you should assess to see if the patient appropriately responded. Did their blood pressure go up? Did their heart rate come down? Did their urine output go up? Did their IVC diameter get bigger? Did their cardiac function get better? So we really feel like not every patient should be abiding by a receipt of 30 mLs per kilo. I think particularly we all know there's a subpopulation of septic shock patients that has biventricular cardiac failure. They have, an ejection fraction of 10 to 20% that is new related to their sepsis. Those patients shouldn't get that much fluid.
So when you're at that point that I know all of us has faced, that you give the fluid and you don't get a response, is that when you now switch to albumin at the University of Michigan?
Yeah, so we would switch and try an albumin bolus and then assess fluid responsiveness. And if, again, there's no response, then we move towards vasopressors and steroids. And, I think an important concept, John, to understand that we really haven't understood until pretty much this year is that a large percentage of patients early after sepsis are not fluid responsive. So there was an interesting study, the Andromeda shock trial that we did in our critical care journal club that was published this year in JAMA. The basic tenet of the trial was just to compare capillary refill as the endpoint of resuscitation versus normalization of lactate for the resuscitation strategy. But in that trial, they assessed fluid responsiveness at hour 0, 2, 4, 6, 8. I don't quite remember how long they did, but we commonly review this in rounds that at hour 0 for septic shock patients, 30% of patients were non-responders to fluid. And at 2 hours, it increased to 70%. And at 3, 4, 6, 8 hours, it was 80 to 90%. So in those patients, vasopressors and steroids, I think, are needed.
Pressors are actually the bridge for those patients who need just that extra time to normalize their intravascular fluid, I guess.
I think so. I think there needs to be greater study of the differences in patients' response to sepsis. And you brought up a good point earlier. Some of these patients have septic shock and hypovolemic shock. They've been at home for days, not drinking, not eating. And that's a very different patient that comes in florid cholangitis and is just horribly vasodilated.
Well, Lena, you've brought it up, so I've got to go there. And that topic is steroids. And there seems to be a resurgence in support for steroids, including some recent articles pointing out that the studies were actually flawed when they concluded that steroids didn't help. You got any comments?
Yeah, this actually has been sort of a performance improvement project for us in critical care. And I co-lead our critical care steering committee with Bob Heisey, who's a medical intensivist who's been here quite a while. And we actually have just within the last 6 months have a quick order for steroids for septic shock that we put in our MyChart, which is our Epic electronic order system. that provides an initial order and then a continuation order. And then very importantly, we're really trying to educate every which way. We made a one-page document reviewing the study findings from 2 large randomized trials that our residents and fellows can open up in that order to review what the study findings are. So what we have concluded now as an institution for our entire critical care steering committee is that steroids are beneficial in septic shock. So there were 2 large trials published just this past year. One trial was the APROX trial, and that trial had a control cohort with no steroids, and then the steroid cohort was hydrocortisone plus fludrocortisone. That study showed a mortality reduction with steroids in 90-day all-cause mortality and also quicker shock reversal. And then the very largest trial, which is the adrenal trial, almost 4,000 patients, also confirmed that steroids were associated with quicker shock resolution. In that study, there was no difference in mortality. So what we did was to put an order set together that says if you have a patient who has been on vasopressors for more than 4 hours, so they are in septic shock, you should initially give them a 50 milligram IV hydrocortisone dose stat. That's the initial order. And then if the patient can get enteral meds, they can get fludrocortisone 50 micrograms PO daily. And then the second order, we gave our teams the ability to use either one of the maintenance steroid dosing strategies used in those 2 trials, hydrocortisone 50 milligrams IV Q6 for 7 days or until ICU discharge was from the APROX trial, and then the continuous infusion at 8.3 milligrams per hour, basically 200 milligrams a day for 7 days, or until ICU discharge from the adrenal trial. So this is now a quick order in our institution, and it's been working really well, and we really like the ability to put the information about the trials in the quick order so that we can educate that we're using an evidence-based approach for this. But I agree with your first comment, which was steroids have made a resurgence in sepsis.
Well, let me ask, do the pressors have to be maxed out or just the patient has to be on them for 4 hours?
Yeah, they don't need to be maxed out, but what we've told everyone, the order says patients on vasopressors greater than or equal to 4 hours. What we would like to see is that you're having a rising dose, that this is not a patient who is on a very small, very low dose of vasopressors, but maybe you were on norepi, you've now added vaso, or you're on escalating doses of norepi.
After going through all this and having some experience doing this, do you really believe this is a true adrenal insufficiency, or is this some other action that the steroids are having, let's say, on the microcirculatory system?
Man, that is the million-dollar question because I don't know. There really is no way carefully to establish a diagnosis of adrenal insufficiency in ICU patients. And so it's very challenging to determine whether it really is adrenal insufficiency or, another possibility is just that it is a relative adrenal insufficiency, meaning we've given these patients a lot of fluid, their cortisol levels are reduced for this state. Just like, when we give patients a lot of fluid, their calcium levels are low and we replete calcium. Just like vasopressin deficiency occurs in septic shock where, we don't think that it's the patient's not making vasopressin, but in part we've given them a lot of fluid, sometimes blood products, and we've diluted them. So I don't really know, and it's again another area where additional investigation would help.
You mentioned pressors and you mentioned norepi and vasopressin. I had a discussion with another of your CSEP colleagues, and the question was, is epinephrine ever helpful in your experience?
I would say resoundingly yes. We have a patient cohort that we find not infrequently, I'd say somewhere between 15 to 20% of the time in our septic shock patients, as I mentioned earlier, who have severe biventricular cardiac failure. And, this is the patient cohort that initially Joe Perillo described years ago that had marked cardiac dysfunction related to severe sepsis and septic shock. And in those patients, we find that just escalating doses of norepi and vasopressin does not do well. I mean, they really have impaired cardiac function. And in that patient population, low-dose epinephrine is sometimes helpful. So what we do in the intensive care unit is if somebody comes in septic shock, one of the very first things we do with initiation of the whole sepsis bundle is to do a point-of-care ultrasound, cardiac ultrasound, to really evaluate cardiac function. And if the patient really has, an EF of 50, 60% and, cardiac function looks normal, norepinephrine, vasopressin, and sometimes angiotensin are useful. But in the patient who has an EF of, 10 to 20%, we recently actually had a 20-year-old woman who was in septic shock in our medical ICU, who we were called for possible ECMO. And she was one who responded beautifully to epinephrine. So I think it is helpful, particularly in the cohort of patients who have biventricular cardiac dysfunction related to septic shock.
I wasn't going to go there, Lena, but I know there is a question on angiotensin in CSAP 17 that did not get published, although I think it's being considered for the specialty module in critical care. So you have any comments on the work that's being identified now that angiotensin may be a valuable adjunct in the treatment of sepsis?
Yeah, we have used angiotensin too, not frequently, but in certain cases where we are on rising doses of sometimes all three drugs, norepinephrine, vasopressin, and epinephrine, and have used it with some good results. It's FDA approved for this shock state. It did have a significant increase in target blood pressure compared to the group that didn't receive it. We feel, in the way we brought it into the institution, because it is a more costly drug, we brought it through our critical care steering committee, and we thought it would be best to allow the ICU clinicians to decide to use it with no need to call the pharmacy to get approval, but that we would keep within a protocol that we would be on high-dose norepinephrine and vasopressin. So we would be on at least 2 vasopressors at high dose and considering a third pressor. And the rationale for that, John, was really that for some patients who have severe tachycardia, adding epinephrine is not the right thing to do. And so in that patient population, we felt strongly that angiotensin II should be made available to the intensivist. It is an attending ICU intensivist approval drug. And we are very careful to teach that it's dosed in nanograms per kilo per minute. And so you have to be very mindful about the dose. And similarly, we created, a quick order for that.
So far, your outcomes, you feel, have been favorable?
Have been favorable. We've had no adverse events. We've had some patients who haven't survived, but related to other issues, meaning, we didn't think it was the fact that we just didn't have a vasopressor that worked.
Well, let's move off this topic, although it's a related topic, and let's talk about infection and antibiotics. So the STOP IT trial was a favorite topic for CSAP 17 committees. And I guess I just ask you, has this been adopted completely for intra-abdominal sepsis in your ICU practice?
Absolutely. Pretty much we talk about this whenever we have a patient with complicated intra-abdominal infection with appropriate source control. And all of our surgeons, we've reviewed it at our, death and complications conference, our grand rounds. We've really fully adopted it for complicated intra-abdominal infection, but with adequate source control. We do 4 days duration of antibiotics. I will say that at the time that we're getting ready to discontinue antibiotics, we will do another look at the patient, and clearly if they're not doing well, we'll alter our approach. And usually it means we're going to reculture the patient, consider, for different infection, consider CT scanning. But in general, we've adopted it fully.
What about the open abdomen that you can't get closed within 4 days?
Yeah, so we have moved to really trying de-resuscitation strategies to move towards closure as quickly as possible. So we really haven't had, I can't even remember the last patient we've had that sort of had tertiary peritonitis, because we moved to closure really quickly.
All right, and then my other probe is, what if you have a septic patient from an abdominal source, you feel you have source control, but you have a positive blood culture that comes back, say, with a gram-negative organism at 48 hours. How do you handle that?
Yeah, that's a really good point, John, because for patients who have concomitant bacteremia, we stick by sort of the old traditional approach of a 2-week course duration for antibiotic therapy. I would love to see a clinical trial that challenges that, because I do think that once you have source control in the abdomen, even if you had bacteremia, it was related to the abdominal infection, and I think a shorter course may be adequate. The one other question we do have, which we didn't quite have, as many patients we would have liked in the initial Stop It trial, are what if the patient had intra-abdominal sepsis, right, but septic shock? And if you had a patient with septic shock, and we're quoting a mortality rate of 40%, is really 4 days adequate. And the Surviving Sepsis campaign guidelines from 2016 currently recommend any patient with septic shock should have 7 to 10 days, modifying that based on their resolution of signs and symptoms of infection, leukocytosis, fever, return of bowel function, etc.
Well, Lena, I've been waiting for those two studies to be done for 50 years.
And we may still wait another 50 years.
So I'm going to leave it to you to figure out how to get those studies done, okay?
Oh, that's a hard task. Hard task.
Let's talk about duration of antibiotics for VAP. And we have a very old study, the Shastri study, which seems to still be holding true, at least in our ICU. How about in yours?
Yeah, the same thing. We still use the 7 to 8 days antibiotic therapy for VAP or HAP based on the Shastra trial. I was fortunate to be part of the 2016 clinical practice guidelines for HAP and VAP by IDSA and the American Thoracic Society. And in that guideline, we also recommended 7-day course for HAP and VAP, not just based on that trial, but based on some other systematic reviews. But I want to qualify this, and I helped to write that part of the guideline, and I was very careful to say that we call everything HAP and VAP, but not all HAPs and VAPs are the same. So, for instance, if you have a VAP with necrotizing pneumonia that you see on CT scan, we have no studies to guide us because all those patients are never included in any of these trials. Similarly, if we have a patient who has HAP or VAP and has an associated empyema or pleural effusion that is infected, we don't know actually what the appropriate antimicrobial therapy duration should be. So from my perspective, we added a statement, and I feel very proud of this. We added a very good statement in our guidelines that states that there are situations where a longer duration of antibiotics may be indicated, and that we should be considering that based on severity of infection and how the patient improves over time based on, clinical, radiologic parameters. We have to be mindful that, we don't have studies for every single type of pneumonia.
I think we're going to have to name this the Lena corollary because you keep talking about personalized treatment and assessment of patients, and I couldn't agree with you more, and sometimes we forget that one size doesn't fit all, and you're to be congratulated for that approach. Before we leave antibiotics, I want to talk about antibiotic stewardship. And you've talked about your multidisciplinary ICU committee. How do you achieve this in your ICU? And is it really accepted by the rank and file surgeons who use your ICU service?
Yeah, this is a really interesting question for me because I would say in general our antibiotic stewardship is in sort of lockstep with our infectious disease group, and they have an antimicrobial stewardship team. But I would say we try to be very good citizens, and in our ICU rounds that we do twice daily, we really carefully review our culture results. We decide whether we can stop antibiotic therapy, whether we can de-escalate to monomicrobial therapy if we're on dual agent therapy. And then we provide really good communication to our surgical services that use our critical care services if we're going to change or stop antibiotics to be certain that we discuss it with them and we keep them informed. And that is accepted without trouble. We have one patient population, our transplant patients, where Transplant ID makes all the antibiotic decisions and we defer to them. And that is a difficult patient population. Those patient outcomes are monitored very carefully, and that sort of comprehensive team wanted that approach, and we ceded to the Transplant ID group. But getting back to antibiotic stewardship, John, I can tell you almost once a day or twice a day, we will get a call, the ICU team will get a call from the antimicrobial stewardship team saying, we are going to stop this antibiotic in your patient, even if we feel we should not. And we have an ability, usually, and the attending will get on the phone and discuss it with the antimicrobial stewardship team member. But if they want to stop it, they do have the authority to stop it. And that has been a bone of contention that we've had difficulty with. And it's rough to get around because they have institutional support behind them. But we know the patients really well.
Lena, I'm glad that someone else has that problem besides me. So now you just made my day.
It's a common thing, I think.
Yes. Now, let me talk about multi-drug resistant organisms. And let me just ask you, which ones do you have a problem with? And then maybe you can give us your opinion about what you think are the ones that we all need to worry about.
Yeah, in this last decade, we've seen a huge change. We really no longer have MRSA at all. And, the gram-positives like VRE are usually colonizers and not really causative in terms of infection. And so in all of our surgical ICUs, we are really dealing with MDR, gram-negative bacteria, and our two most problematic isolates are really Pseudomonas and Enterobacter as MDR pathogens in the ICU, which creates a bit of a problem for stewardship because then there is this push to really reduce the use of carbapenems and to have a carbapenem-sparing strategy in the ICU. On the other hand, the most common pathogens in our ICU are gram-negatives, which need carbapenems because they're resistant. So it's a challenging time, and it's vastly different from a decade ago where we had MRSA as a common pathogen.
So true. My only comment would be we have Acinetobacter instead of Enterobacter in our unit, but the same thing, and the call I get most commonly is to stop the carbapenem. So I suspect just like you.
Very similar, and we don't have an Acinetobacter problem except on rare occasion, maybe once a year, where we get a transfer patient in. And getting back to antimicrobial stewardship, one of the sort of innovative things we did is to put all of our transfer patients in isolation and swab them to really identify because Acinetobacter can, travel around your ICU pretty quickly. So that's worked pretty well for us.
My final question about antibiotics is the antibiotic pipeline dead, or will we really see new antimicrobial agents in the next few years?
Well, I hope it's not dead. We certainly need some new agents. And, there are a number of new gram-negative, mostly combination agents that are in the pipeline. Really, I think sort of on a good news note, the FDA has approved quite a number of new combination antibiotics for gram-negative bacteria over the last couple of years. Meropenem vapor-bactam, ceftazidime-avibactam. Some of the two newer ones just within this year are imipenem rilibactam and eravacycline. I mean, all of those are agents for MDRO pathogens. I really think the future will have additional agents. There are some additional ones in the pipeline, but I see a huge challenge facing us. We are both reviewing that gram-negative MDRO pathogens are our nemesis here. And I think the most significant challenge in the future is going to be how to determine to really best use these new agents, because most of them are going to be available in most institutions only with ID consultation, given a significant concern I think that our ID group would have about potentially developing more drug-resistant pathogens. So challenges for the future, but I think, the antibiotic pipeline's not dead. It is reduced in size.
Okay. All right. That's fair. Well, let's talk about another infection, nosocomial and community, but it was a favorite question in CSEP 17, and that was Clostridial difficile colitis. First, what are the risk factors you emphasize when you talk about this with your residents and your fellows?
Yeah, our biggest risk factor is prior antimicrobial therapy, hence our discussion about, trying to get the antibiotics off, being good stewards of antibiotics.
Okay. How do you make the diagnosis at the University of Michigan?
Yeah, we do a two-step process that we've done for a while, which really has served us well. We do an ELISA for glutamate dehydrogenase and toxin AB. And that's then the first step. So if you get both positive, then C. diff infection is diagnosed. If they're both negative, then C. diff is not diagnosed. The second step is, what if you have mixed results? So GDH is positive, toxins negative, or GDH is negative, toxins positive. If you get mixed results, we then do a PCR. That's served us well, but I would say the one change in testing this year at the University of Michigan, which is a big change for us, is that clinical teams are not being allowed to send samples for C. diff testing if there is not diarrhea and additional risk factors like colitis, megacolon, CT findings of colon thickening, very high leukocytosis, those kinds of things. This again goes back to antimicrobial stewardship. The concern is that if we test without those, we will be picking up C. diff that is from the community and is a colonizer and not a true infection. Now, we'll have to see how this goes because this just got started this year. And in the ICU, we've had a couple of cases where the ICU team felt strongly we should test for it, and the ID team did not. And so, again, we get on the phone and come to some sort of conclusion of what to do.
Actually, we started that about a year ago in Milwaukee, just before I left, and we actually fought it at first, but after a while, it does make sense, and we did not feel we were losing or losing somebody who we really thought was infected.
Yeah, I think if we get on the phone and say we're concerned about this patient for this reason, then they'll let us go ahead and send it.
Yeah. So I'm assuming they get put in isolation, correct?
Correct.
And when do you let them come out of isolation? Ever?
No. So during that hospitalization, not. And then the problem is, if they're readmitted like a week later, they're still going to be put in isolation because we know that they harbor it for a period of time.
Okay, a month later.
Yeah, same thing. They'd be in isolation.
We put a sticker on the chart, and so far we haven't figured out how to get the sticker off.
Yeah, I guess, a year later we would probably retest them, but I don't know of any patients like that.
Okay, all right. Now, there have also been some treatment changes since CSEP 16. Is that not true?
Absolutely. So new IDSA guideline has been published, and very significant changes for C. difficile treatment in general and based on severity that are very important for clinicians to know. And many times in our acute care surgery rounds, we'll bring up the table from the IDSA C. diff guideline. But to summarize pretty briefly, the biggest change is that metronidazole flagyl is no longer recommended as first-line therapy in adults. So that is a huge change, and PO vancomycin or PO fidaxomicin are the first-line recommended treatments.
And in your institution, has fidaxomicin begun to replace vancomycin, or is still vancomycin the old standby?
Vancomycin is the old standby, and fidaxomicin is used less frequently because it is more costly. On the good news side, I would say, though, that this change was, based on evidence in that either of these provide the patient with really the highest likelihood of sustained resolution of infection early after treatment. So I think it's a good move.
And duration of treatment?
Yeah, so duration of treatment is dependent in part on severity. That's very important. And then duration of treatment is also, dependent on that you're seeing resolution of, again, signs and symptoms. But the treatment is 10 to 14 days. Then the real question and additional changes in the guidelines are related to recurrence, because many of these patients will develop recurrence.
Yes, how true. And then I'll ask, do you use a different drug, or are you going right to fecal transplant?
Yes, so our standard has been that if the patient was on oral vancomycin as the first treatment strategy, that would be a time that then for a recurrence, we would consider for the first recurrence fidaxomicin. So we do change drug. And then for a second recurrence, we would go to fecal transplantation.
And is this a homemade fecal transplantation at U of M?
Yeah, no, it's not. It's utilizing the now commercially available capsules that are available, which I think is a good thing.
So the capsules, how are the capsules used? Because I have no experience with those.
John, I will say that I don't know either, because I certainly haven't taken them, but
okay, all right.
I haven't actually seen how patients take them, but I think they just take them orally.
Is that right? Okay,
yeah.
All right. So we've mentioned fidaxomicin. Are there any new drugs on the horizon for treating C. diff?
Yeah, well, there's been a drug out since a couple of years ago, bezlotuximab. Bezlotuximab is a human monoclonal antibody against C. diff toxin. And in its initial trials, there were two large randomized trials that were done. It had significantly lower rates of recurrent infection than placebo. We have used it on very rare occasion for patients who have had multiple recurrences and still are getting recurrences. The biggest issue with bezlotuximab is that the way they did the trials is the control cohort was a placebo cohort. So the big question I think that all of us have is it hadn't been tested against fidaxomicin, which is another drug that also reduces recurrence. And so we would like to see a trial that actually would compare the two drugs, a monoclonal antibody versus fidaxomicin.
Well, you just, with that little dialogue, you just stimulated a thought about the fecal transplant. And Dale Girding, it's now got to be at least 3 years ago, published an article about placing non-toxigenic C. diff in people's colons after they've had multiple recurrences. I've not seen any follow-up to that. Have you?
No, I have not either. We instead try to focus on repopulating the gut to resume a more normal microbiome. So stay away from antibiotics, eat some yogurt, the usual simple things. I've not seen anything about, a non-toxigenic C. diff for repopulation, but it's an interesting topic.
That's the end of this session for this category of the CSAP 17 audio companion. This category will continue in the next session.